run you through a little bit different scenario than we've had in this convention so far, but just to give you an idea of what we're about. We have a technology platform that we call Resonant Molecular Signaling, and it ought to resonate with this group. We're convinced that good health depends on typical communication between and among within and among cells. Any disruption of that signaling will result in disease. It can be acute like a stroke or chronic like rheumatoid arthritis. Our goal using resonant molecular signaling is simply to use molecules, and oftentimes fractions of molecules, to restore communication and let the body do what it's supposed to do. The therapeutic agents that we use in resonant molecular signaling are, as a group, selected after studying the pathophysiology of disease. What we're interested in is we look at a disease, disease X, whatever it might be, look at the sequence of events leading from initiation of disease to occurrence of signs and symptoms, and see where we can interfere with that. Then think about a molecule that might be able to do that interference. And we come up with these molecules either just brainstorming, maybe reading the literature, or just by trial and error. With but one exception, all the molecules we use therapeutically are naturally occurring. They are often well studied, but also, with but one exception, they've never been used therapeutically before. So they're altogether different than what's on the market now. They are safe, and we have done, I think we're into our 16th phase 2 FDA trial. We've done a couple of USDA trials also. In all of those trials, the safety profile for the placebo group is the same as for the treated group. So these things are safe. Very interesting is they are stable at all these different temperatures. That's interesting because some of these molecules are enzymes or hormones, and those of you that work in biology know that those are not stable at room temperature or at pocket temperature, things like that. They are not stable with respect to their enzymatic or hormonal activity, but that's not what we're looking at. We're looking at a different kind of activity. And we administer these in what we call physiologic doses, much more concentrated than a remedy that would be associated with homeopathy, but less concentrated than might be a normal physiologic or allopathic dose. We're convinced that these agents that we use act as nothing more than signals to stimulate a cascade of events that results in the desired outcome. Of interest is there's no relationship between patient mass and the dose that we use. So a 2,000-pound horse gets the same dose as a 5-pound chihuahua or a 150-pound man. The frequency of dosing can change, but never the dose itself. Also of interest is we can use different routes of administration with the same dose, get the same response in the same amount of time. You can't think of very many medicines that do that. That again gives us a hint that these are simply acting as signals. What I want to do today is focus on just one of these therapeutic agents as kind of the prototype for our platform. And this is streptolysin O. That scribble on the right is supposed to resemble three-dimensional structure of streptolysin O. I don't know if it does or not. I've never seen it, but that's what comes out of the literature. This is a molecule that you're all familiar with one way or another. This is the toxin from group A beta hemolytic strep that causes a sore throat. And this is the toxin that causes a sore throat. We use it as a therapeutic agent in a little bit different situation in that we modify the toxin, we reduce it. It's toxic in its reduced state. We modify it to the oxidized state. It loses its toxicity and gains therapeutic activity of a different way. That's the modification. Well, there we go. Now, one might wonder, what the heck, why would we ever use streptolysin O as a therapeutic agent in the first place? There was a paper presented, oh gosh, it's got to be 8 or 9 years ago now, by a professor at Brown University at the medical school. And this gal did some epidemiological work to show that movement disorders like Tourette's and tics and things like that in adults could be related to a childhood history of chronic or repeated strep infections. We wondered, what the heck could that relationship be? That is, clearly the organism was no longer there in the adult, and yet we had these symptoms. What might be happening? And we thought there might be a situation involved with an aberrant immune response to the original infection that persisted throughout life and could cause these problems. So what we did was obtain some very highly purified streptolysin O, We oxidized it, that's the modification step. Then we had to find a patient with this kind of a problem. And we found one, a patient that was in the practice of one of the physicians in our group who had a horrible tick of the neck and head. She was always going like this, about every 6 or 7 seconds. If you sat in the examination room with her, within 3 or 4 minutes, you're going like this too. Everybody's doing this. She was 34 years old at the time of initiation of therapy. She was being treated by this physician for another problem, but he contacted her and said, listen, Mary, would you be interested in trying this kind of left-wing wacko approach to seeing if we could do anything with your tick? We're confident it'll be safe. We haven't the foggiest idea if it's going to do you any good. She said, yep, let's give it a try. So she came to the clinic. She was instructed to take 1 drop under her tongue of this modified streptolysin 4 times a day, come back in 4 weeks. She did that, and at the end of the 4 weeks she came back, and clearly her tick was reduced, but it was not gone. The physician had the good sense to say, well, gosh, Mary, did you see anything else, good or bad, that occurred during this 4-week period? And she goes like this, wham, just about punched the guy out. And she said, look at this. Well, yeah, close up. And he said, a very nice looking fist. What am I looking at? And she said, well, when I was 8 or 9 years old, I was in my mother's kitchen, and I pulled a saucepan of boiling water off the stove onto my hand. And I burned my knuckles very badly, scarred, we thought permanently, and in 4 weeks those scars are gone. Whoa, that's kind of interesting. How do you make scars go away? You're taking a drop under the tongue, and this gal's scars disappear. So we thought, well, geez, oh man, that might be kind of interesting all by itself. And we brought other patients in who had superficial scars of this sort that we could see, and we found that, yes, indeed, without exception, we could certainly reduce the scars and sometimes make them go away completely in a 4-week period, again, taking sublingual drops, and it didn't matter where the scars were. As we got more and more into this, we found that the spectrum of targets for SLO therapy expanded far beyond scars. And we'll take a look at some of that a little bit later today, but wanted to give you an idea of some of the problems that we had trying to get our heads around what the heck's going on here. We said, what does SLO do? This little photomicrograph collection is from collaborative work we did with investigators at NYU. And what we have here, whoops, whichever hand has the pointer, what we have here is human tissue grown on a microscope slide. We cut the tissue with a scalpel, and then you'll see that we've used 2 different concentrations of SLO, exposed some cells, that is, some cells on microscope slides to SLO, and have controls here. And what we're measuring is the rate at which the gap closes. This is superficial healing. And what we found was that there is an incredibly increased rate of activation and mobilization of keratinocytes that causes closing of the gap much faster than would happen under normal conditions. Well, great. Let's go a little bit deeper in that and see what genes are up and down regulated as a consequence of SLO exposure. And we're certainly not going to go through all this, but there are a couple important things here that you maybe heard of. CD44 antigen, especially important in aligning collagen in proper sequence for scar formation, for wound repair, and so forth. And we are upregulating that. That's an anti-inflammatory cytokine also. So we're getting anti-inflammatory effects from SLO. This one, some of you might even take chondroitin nutritional supplement. If you have arthritis in your knee or a sore elbow, chondroitin is a typical nutritional supplement for that. We think it's better to induce the body to generate its own. And we can do it with SLO and a couple other molecules we use. But complementarily to the upregulation of these anti-inflammatory cytokines was the downregulation of pro-inflammatory cytokines. Extremely important, especially this guy, which probably most of you have never heard of, the matrix metalloproteinases. These are a collective group of enzymes that are implicated in a variety of diseases ranging, and this is not being flippant about it, ranging from sore throats to cancer. These are really, really dynamic proteins, and when they are upregulated, there's nothing but trouble. The pharmaceutical industry over the last 8 years has spent over $6 billion to find inhibitors of MMP9 and MMP2. They often go hand in hand. 2 is not on this list because although we downregulated it in this experiment, it wasn't to a statistically significant level. The point is that we are simultaneously upregulating anti-inflammatory cytokines, downregulating pro-inflammatory cytokines, and downregulating MMP9, and we'll see what that means here in a little while. So let's look at some practical applications of what we're finding with streptolysin O. These 4 experiments are going to get about 2 minutes each. These are all done in horses, all done with collaboration with investigators at the University of Kentucky or with practicing veterinarians in the large equine practices in the Lexington area. All the animals we're going to look at are extremely expensive thoroughbreds that have diseases for which there isn't much to offer. First off the bat, that's a horse's leg, actually 2 legs of horses. And what we're interested in here is right here. Oftentimes, a horse will get injured, that tendon gets damaged, and one of the consequences of that is, besides the horse limping and not being able to be athletic anymore, is that the tendon will tighten up and the hoof will lose its normal orientation to the ground. The horse will be unable to use that leg anymore. It'll go down and it won't come back up. That'll be a horse that's going to be put to sleep. What is done for therapy for this oftentimes is to cut this tendon. And what that does is release the pressure that's occurring as a result of the tightening. After the injury, scar tissue forms. There's a tightening as cross-linkage of collagen occurs. The tendon becomes less flexible. Now we're going to cut it. That allows the hoof to regain its orientation a little bit better. But what happens when you do something like that? You actually generate scar tissue also. And so we have a tenotomy. That's the cutting of the tendon that's going to occur with this situation. What we want to do is decrease or eliminate the scar tissue that forms after the tenotomy. And we're going to do that using SLO, which we find alters the ratio of collagen to collagenase. Collagenase breaks down collagen, allows it to be replaced by more vital tissue. And here's what we have, and we're certainly not going to go through all this stuff, except look at the pretty colors. What we're after in this is we would like to see the dark purple being shorter than the light purple or the blue. And this looks at post versus pre. And what we're doing here is sonography, where we're using sonogram on the area where the tenotomy is done. So we get quite objective measurements of the amount of scar tissue by looking at 3-dimensional cross sections of the tissue. It all comes out, that is, the measurements come out at a computer. So again, it's objective. And what we want to have is smaller cross-sectional areas in the post, this color, versus the pre. Here looks pretty good. This is after 30 days treatment. That looks pretty good. That's a turkey. That's exactly wrong. And what went wrong? Dumb horse stepped in a hole during the 4 weeks of therapy and re-injured itself. That's the way it goes. This is a kind of a fun one in that you can see we're gaining a lot here. We're starting to see something here after 30 days. The importance is this animal had a tenotomy 7 years ago. That's an old scar. And to get any resolution or a hint of resolution after that period is something that is fairly unheard of. And you can see the stats here. We get 50 to 30% resolution in 30 days. That's a start on something that could be quite useful. Another problem with horses, again, for which there's little therapy, especially in these thoroughbreds, it's a problem, are cervical adhesions. These adhesions occur after especially multiple births. Just the act of birthing results in scar tissue formation. And what we have here are 11 mares. These are all high-priced thoroughbred mares that are barren, which means that they are really only good for dog food anymore. We have an accepted, these are called Kinney scores. Here we've done biopsies prior to SLO therapy of the cervical region of the horse, and the Kinney scores go from 1 to 3. And there's a 2 and a 2B. You'll see in here, the higher the number, the more seriously afflicted the horse. Here we have the years which the mares have been barren. Here's the expected foaling rate, or the foaling percentage, 38%. Look at this. You get something like number 10, has a Kinney score of 3. That's as bad as it gets. It's barren for a year. It only has a 10% chance of ever having a live foal. Okay? This is a $500,000 mare. And she's not a racing mare. She's a brood mare. And she's not worth much if she can't have a foal. So after 30 days of therapy with SLO, she was bred, the breeding was successful, the fetus was maintained, she had a live birth, all was well. So bottom line is right down there in the corner, we had just a dinky little study, but it looks like SLO is doing something. And remember, this SLO is being introduced in these cases by a tiny injection in the neck to heal scarring in the uterus or in the cervix. Okay, so we're getting a systemic reaction that way. Now, this is where it really gets exciting. No, this is kind of fun. We're going to look at a mare's uterus. Don't blush. There's nothing pornographic about this. What we're going to look at is this is a $750,000 mare that had a colt, a good healthy colt, and after giving birth had a horrible uterine infection. So as is typical for treating that sort of a case, the uterus was drenched with antibiotic. The problem was the attending veterinarian didn't realize the horse was allergic to that antibiotic. So there was a terrible allergic reaction, inflammatory reaction in this uterus as a consequence of therapy. Now, what we're going to do, if I can remember how to do it, is this. We have a camera inside the uterus, and I know this isn't the sort of thing you pay big bucks for, but what we're looking at is the degree of scarring in this uterus. And we're going to see in a second, this thing only lasts for 20 or 30 seconds. Look, those strands in there that are white, that look, some of them we'll see kind of look like stalactites and stalagmites, and they form columns. That's all connective tissue. And there's no way on earth that this mare is ever going to be able to maintain a fetus with a uterus like that. So we treated her with SLO for 45 days. She was bred successfully, and she's had 3 live foals since that one treatment. So again, that's a big deal in the horse industry. The last thing to talk about horses, the last thing we want to look at, is a recently completed study we did at the University of Kentucky. Rhodococcus equi is a soil-borne bacterium that infects young foals when they're out in the pasture kicking around and learning how to walk and things like that. They breathe in dust that's contaminated with this organism, and they get pneumonia. And pneumonia can be fatal or it can be chronic. What we did was artificially infect some foals with Rhodococcus equi, and we divided them then into 4 groups. Those treated with just saline, those treated with SLO alone, with the typical antibiotic therapy alone, and the combination of antibiotics, that's what the AB stands for, and SLO. Now the reason for this is that in the usual route of infection, or the usual consequence of infection, the pathophysiology of this disease is that the organism gets in the lung of the horses. It can cause immediate damage there to the point of fatality for the young foal, or it can cause a chronic condition. Regardless of which it does, well, if the foal survives, it's going to be compromised the rest of its life because of a reduced respiratory capacity. Also of interest is that the organism becomes encapsulated within the lung. Later in life, that capsule can break down, live organisms can be spewed out, and any time infection can occur again. The reason that we wanted to try SLO in combination with the antibiotics was to prevent that encapsulation, because if encapsulation occurs, the antibiotic can never reach the organism, so you can't kill it. So those are the results of this little experiment. The clinical score is a determination made by the attending veterinarian who's blinded as to which horse is in which of the 4 groups I mentioned, and we got a p-value, not bad, of 0.05, in that the treated animals, that is treated with the antibiotic plus SLO, were better off than those with antibiotic alone. Also, we saw the 30+% reduction in pneumonia scores in the combination, another nice p-value. But, whoops, wrong hand. Look at this guy down here. This is really interesting here. We're getting less collagen, and that, remember, that's going to be the primary component in the encapsulation process down here, so that the organism that is causing the problem is going to be exposed more efficiently to the antibiotics, and a nice p-value. So what? Who cares about all these horses? Well, we do in part because this is a recognized model for that, TB in humans. Tuberculosis in humans has the same situation. Breathe in the organism, it can become encapsulated. Those capsules are called tubercles. You can pick them up on chest x-rays. In this country, we don't get really excited about tuberculosis anymore. there are between 50 and 55,000 new cases per year. Worldwide, believe it or not, 1/3 of the world's population has tuberculosis. That's a pretty big bunch. Now, some of these people that have it are going to suffer the acute infection and die early on. For a lot of people, it's going to be a chronic infection that might become acute at any time as a result of breaking down of the capsule, or the tubercle in this case, to release the organism. We have a study planned in India where we will do in people that are afflicted with Mycobacterium tuberculosis, the causative agent. We're going to do the same experiment that we did in the horses in Kentucky. We are going to combine antibiotics with SLO to see if we can break down the capsule that's forming the tubercle, expose the organism to the antibiotic, and clear the people so that they are no longer chronically infected. The importance of that is twofold. One is typical antibiotic therapy for TB now lasts 6 months. It's hard to keep anybody on any regimen for 6 months. So people are going to be chronic carriers for long times. Second thing is, the longer an organism is exposed to an antibiotic, the greater the chance of an antibiotic-resistant strain developing. So what we want to do is see if we can reduce the clinical time of treatment for tuberculosis from 6 months to 1 or 2 months. Just doing that. Understanding that SLO has no antimicrobial activity of its own. It's got to be used in conjunction with the antibiotics, but we think we might be able to help. Now, we've talked about some internal scarring associated diseases with horses. We looked at the legs of the one horse and the uterus and the cervix and so forth. What about humans? These first 4 dot points represent some of the diseases we've treated successfully using SLO. These are all scar-related diseases. Cardiomyopathy, horrible disease. We've had a couple patients that were on the cardiac transplant list that are no longer on it. So that's a good sign. Polycystic kidney disease, responds quickly. Surgical adhesions are a big problem, especially with gut surgery or gynecological surgery. We can make those surgical adhesions pretty much disappear. The range of motion for all of us decreases with age, in part because of adhesions. And we have a little study, actually a pretty good sized study, ready to start later this year at Yale University Medical School, where we will treat patients with complications of total knee replacement surgery, because anecdotally we've seen these patients get a heck of a lot better with SLO therapy. We are just now starting to put our foot in the water with respect to treating concussions. Scarring in the brain is a little bit different than scarring elsewhere in the body. We're not sure what will happen here, but we're working with 2 groups on this project, or this proposed project. One is with the people at the medical school in Johnson City, Tennessee, Eastern Tennessee Medical School. The other group is called the National Football League. And we're going to see if SLO can do anything to help recovery from concussions. We've talked a little bit about external scars in humans. One of the first patients was, well, maybe I didn't tell you about that. I told you about the gal that tried to punch out the physician. One of the other patients that we brought in was a man in his mid-70s, 75, 76 years old, who had acne scars since his teenage years. And in 4 weeks, those flattened out. Okay, so this is a hint of another use for this, and trauma-induced scars, stretch marks, and all that. That's great. What about if we used SLO to prevent scars, rather than to just treat them? Well, this is a picture of a gal's face just after she went through a windshield. There's her chin, here's her teeth. Her nose has been torn off and displaced to the right. She's in trouble. At the time of the picture, she's at the emergency room at the Medical University of South Carolina. She's getting sewed up here. You can see there's going to be a problem with the scar here. Look at the position of this tube. The right side of her mouth has been ripped out. They've got her nose back on now, but there's going to be some scarring there, some scar over the eyes, and so forth. Her mother is a nurse in one of the practices that's in our group. When she got the call from the medical school saying that her daughter had been in the accident, she ran out the door and said, "Can I take some SLO with me?" And of course she did. And this patient then started SLO, again, just a drop under the tongue 4 times a day, the day of her accident. Whoops, wrong button. Here she is, looking pretty great, don't you think? Looks like she might have a scar on her left cheek there. Going to have a scar on her nose. she's in trouble. There she is 3 weeks later. And if you look, she still has a scar. Something that, by the way, all these pictures are taken by her mother, who's not a professional photographer. There she is a month after the last picture. Again, that scar is still flattening out. It's got a ways to go yet, but that's not too bad. You don't see much around the nose at all. Look at that. That's coming right along. This is a step in the right direction. Now the physicians in our group use SLO routinely for patients before they go into therapy. And what we have found is the patients heal with little or no scarring. After, did I say after therapy? After surgery. Before they go into surgery, they're healing with little or no scarring. They don't need as much analgesia after surgery. And again, we know some reason about that. We saw the upregulation of the anti-inflammatory, downregulation of pro-inflammatory cytokines. And they heal much quicker, and they heal without adhesions. Now, well, let's go back to this young lady for a second so I can introduce you to that next slide. This is all great stuff. Hooray, you know, great. We can do something with scars. But it still doesn't get to the point that we were asking at the very start of this tirade that I'm giving you. That was, we mentioned that this platform, the resonant molecular signaling platform that we've developed, is making an assumption that the therapeutic agents that we use are simply acting as signals. And again, if you can use the same product for a 2,000-pound horse as a cat, and which we do, good. It works just like that. It works super. But what's the nature of the signal? Well, we're not smart enough to figure it out ourselves. So we asked the help of the personnel at what's called the Center for Cell Signaling at the medical school at the University of Virginia. David Brodigan is the director of that program down there. We got in touch with him, sent him some of the data and a whole lot more, some of the data you've seen here and an awful lot more, and said, can you help us figure out what's going on here? He looked at all the data. He says, I've never seen anything like it. And this is the guy that's the director of cell signaling. I said, well, can you help us anyway? He said, let's do this. We've got some in vitro assays. We do a lot of cancer work down here at University of Virginia. We have some in vitro assays. You'll recall one of the slides way back showed downregulation of MMP9. That's one of the markers that's associated with cancer. He said, let's take a look, since you've got this data about MMP9, let's see if SLO does anything in one of our in vitro assays, and that'll give us a handle on where to go next. So now we get to look at this slide. What we have here, whoops, in the top four little pictures are photomicrographs of cells that have passed through a gel matrix that reflects the ability of those cells to metastasize in the human body. These cells are of human breast cancer origin. They are the most aggressive form of breast cancer in humans. Okay? Now look, all we're doing, without getting into too much detail, is counting the number of cells that have made it through the matrix. That's an indication of their degree of metastatic ability. Okay? And you look at different concentrations of SLO, and you have progressively fewer cells making it through. These bar graphs simply show, in this form, what we're seeing in these pictures. Okay? And each one of these is statistically significant. So now we have a product that not only does something with scars, but it looks like it inhibits metastasis. When Dr. Brodigan at UVA saw this, the first thing he said was, every woman over 40 should be taking SLO. And this is the guy that works with cancer all the time. Well, maybe yes, maybe no. The point of it is that we are now in our laboratories in Providence, Rhode Island, doing some work to see if what Brodigan saw in vitro in Virginia can be reproduced in vivo. Will we really show that decrease in metastatic activity? To round this all up, resonant molecular signaling is the platform that we've developed. I'm confident that all we're doing is bridging biochemistry and biophysics. We can explain everything we see biochemically, but that's not the right answer. There's more going at a different level, which I'm calling biophysics, and that gets us to this question of what's the nature of the signal. The reason we're asking that question is not for academic purposes, but we think that other modalities might be identified that could be more efficient than what we're doing. It might be sound, might be light, might be electromagnetic force, any of those. I have in parentheses bone healing there just as kind of an aside to tell you that you all know that you can use magnets to stimulate bone healing, right? That's been in the literature. Hospitals use that all the time now. We have a molecule it's called calmodulin, that stimulates bone healing faster than a magnet. What's the common denominator between the calmodulin, the biochemical approach, and the magnet, the biophysical? We don't know. We need help. That's why I'm here. And for that, I thank you.
Looking for questions? I imagine there'll be one or two. I have to tell you that I've spoken at John's annual conference of his Beech Tree Labs, and it's a mini version of SSE, and he calls the members beech nuts. Yeah.
Thank you. Boy, that was really inspiring. I understand that one of the reasons why spinal cord injuries after a period of time cannot be healed is because of scar tissue. Is there a possibility that this will work with that kind of thing if applied immediately after an injury?
It does work. We've done it.
One of the articles that I make my students, undergraduate students, read is an article on use of stem cells in that very injury in horses, and it reported that there was very good results from it. Have you looked at the comparison with the use of stem cells or using stem cells in connection with SLO?
We've not done any comparative work other than through the experiences of the attending veterinarians that come from some of these really big clinics in the Lexington area. And from their experiences, their observations, the results are pretty much similar. They like the SLO because it's easier and cheaper.
Easier and cheaper. Oh, good.
John, I'm wondering if you've tried, you mentioned horses, I'm wondering if you have tried anything with dairy cattle, in particular mastitis or Bang's disease?
Yeah, nothing with Bang's, lots with Staph aureus-induced mastitis. And I would say our success has been limited, primarily because the farmers don't want to keep up the therapy. But we have had some degree of success. We have not done a real trial with it. We have veterinarians in our group who do use it routinely.
And finally, I think I can help you get some of your answers.
I appreciate it. Thank you.
Just on theory behind all this, have you ever encountered papers on non-contact friction?
No.
Sound familiar?
No. No.
I think you're on the bottom floor of a whole field of science that any atom molecule has an intense virtual photon field around it. That's sort of like not recognized by physics, but it's just starting to become that. And that non-contact friction is that separate molecules, 100 nanometers apart, have very strong friction between them for like AFM microscope stuff.
Well, I would love to be introduced to it. Thank you.
But like look up non-contact friction.
We'll do it. Thank you.
I have a question and a comment. I'm interested in the dose response efficacy, because if this is a molecular signaling kind of effect, you might expect it to be dose independent, but I saw your dose response curve in the last graph kind of indicating that it's acting like a ordinary biochemical kind of
That's the first
thing.
time we've ever seen anything like that with SLO.
So nonetheless, I wonder if you had done any experiments going in the other direction, like toward the ultra low dilutions.
We've done lots of that with the idea of hormesis involved.
Yeah,
Yes,
right.
absolutely we have.
And it works at ultra low doses as
Actually,
well?
these are relatively ultra low doses, and we get the classic U-shaped or J-shaped curve that's associated with hormesis. And these doses that I'm talking about are at the bottom of that U.
Okay, okay, so that's
They are it. A higher dose, clinically, a higher dose will give us no response, and a lower dose will give us no response.
okay.
There is a window with that
Right.
U-shaped curve.
Okay, so that's encouraging. And as far as testing the hypothesis that there's some endogenous electromagnetic field which might carry the information like my laser last night, you could do experiments looking for synergism between the chemical and an exogenous electromagnetic field to see if there's any coupling or synergism between the two.
That's where we need help because we're too dumb to do those sorts of experiments.
There we go. That's what we're doing.
Thank you, John.
You're welcome. Bill?
Didn't see you behind me.
Thanks. John, I was wondering if you also have looked for a dose response curve, the U-shaped thing, with respect to the frequency of repetition of the dose.
Yes. And it's interesting you ask. We can use a light switch as an example of what happens and all that. You can turn a light switch on gently, or you can smash the heck out of it, but you don't get any different response, right? It either turns on or it doesn't. What we find is that especially in acute diseases, if we, in a sense, pulse therapy, we get a better result early on, and then we can reduce the frequency of administration, but we keep the dose the same. So it's like flicking the light switch on and off. We think it's more important to have multiple inputs than one big one. And so, yes, and for example, with rheumatoid arthritis, we have a formulation that we use for that. Person is in extreme pain, they're still going to take sublingual drops. We would ask them to take a sublingual drop every 15 minutes for an hour. Usually within the hour, that pain starts to resolve. After they get over that threshold where pain reduction has begun, they can decrease the frequency of drop, maintain the same concentration, and they'll be fine.
If they don't decrease the frequency at that
Oh,
point?
it won't hurt them any. It's
will
just
they-
wasted drops.
Oh, sorry.
It's just
Okay.
wasted drops. It
Okay.
doesn't hurt them any.
So it doesn't,
It doesn't overdose them.
okay.
Nope. Okay, thanks.
Thank you again, John.
Yep.